Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 304 of our pharmacotherapy series, which majors in chronic stable angina. The first question relates to patient JAP in part 303 of this pharmacotherapy series. JAP states he had heard that antioxidants such as vitamin E could benefit him along with a daily B vitamin. Would these supplements offer significant cardiovascular benefit for JAP? Because oxidation of LDL in the arterial wall is a key step in the atherosclerotic process, considerable interest exists in the theory that supplementation with high doses of antioxidants such as vitamin E, vitamin C, and beta-carotene might mitigate this process and slow the progression of atherosclerosis. Early observational studies of antioxidants seem to confirm this theory. Multiple large randomized studies, however, have shown no positive effect from supplemental intake of antioxidants such as vitamin E on the incidence of cardiovascular outcomes including myocardial infarction or death. These findings were observed in both primary and secondary prevention of cardiovascular events. JAP should be informed that supplemental intake of vitamin E will not have any positive effect on his cardiovascular disease. Interest in the use of supplemental intake of folic acid and B vitamins stems from their ability to lower homocysteine levels. It is well established that elevated levels of homocysteine are associated with a higher incidence of cardiovascular disease. Despite this association, the great majority of appropriately designed, randomized, placebo-controlled studies have demonstrated that supplemental ingestion of folic acid and B vitamins has no impact in reducing cardiovascular outcomes such as myocardial infarction or death. Therefore, similar to the advice for vitamin E, JAP should be counseled that folic acid and B vitamin supplementation will not provide any tangible cardiovascular benefit. The next question reads, should JAP receive a prescription for sublingual nitroglycerin on discharge from the hospital? If so, what education should JAP receive with regard to the use and storage of sublingual nitroglycerin? All patients with coronary artery disease, especially those with chronic stable angina, should receive a prescription for sublingual nitroglycerin for the treatment of acute anginal attacks. Nitroglycerin leads to vasodilation of both veins and arteries, which reduces myocardial oxygen demand, thereby relieving angina. Because response to nitroglycerin varies among patients, the dosage should be individualized. Most patients, however, use a dose of 0.4 mg. The administration of sublingual nitroglycerin is also useful in patients who have a good understanding of what level of exertion produces their chest pain. About 5 to 10 minutes before JAP is about to undergo heavy exertion, he can take a sublingual nitroglycerin tablet to prevent angina. Patient education is a crucial component of ensuring sublingual nitroglycerin is used appropriately to treat acute anginal attacks. When angina occurs, JAP should sit down immediately and utilize his sublingual nitroglycerin. If using tablets, he should place the nitroglycerin tablet under his tongue, he should not swallow it. If using the nitroglycerin spray, he should apply the spray on or under the tongue and not swallow or inhale it. Many patients experience dizziness and lightheadedness, which is minimized by sitting. The onset of action is within 1 to 2 minutes, and pain usually is relieved within 3 to 5 minutes. If the pain persists or is unimproved 5 minutes after the first dose of nitroglycerin, the patient should call 911 as they may be experiencing a myocardial infarction. If he needs more than one dose, he can take a maximum of 1.2 mg in 15 minutes. The tablets should be dispensed in the original, unopened manufacturer's container and stored in the original brown bottle. Because sublingual nitroglycerin tablets are degraded by heat, moisture, and light, they should be stored in a cool, dry place, but not refrigerated. The bottle should be closed tightly after each opening. Safety caps should not be used, although patients should be cautioned to keep all medications out of the reach of children. The cotton plug sometimes is difficult to remove. Therefore, it should be discarded on initial receipt of the prescription and should not be replaced. Use of cotton other than that supplied by the manufacturer should be discouraged because nitroglycerin tablets are volatile and are adsorbed by household cotton. This results in a significant loss in tablet effectiveness. Expiration dating should be monitored closely, and tablets should be replaced immediately if they are exposed to excessive light, heat, moisture, or air. Once a container is opened, the tablets should be used for only a limited time, usually from 6 months to 1 year. The next question reads, given JAP's active lifestyle and recent history of frequent anginal attacks, the medical team wishes to optimize chronic preventative therapy for chronic stable angina. JAP currently is receiving metformin 500 mg twice daily, lisinopril 10 mg once daily, and hydrochlorothiazide 25 mg once daily. His current resting heart rate and BP are 78 beats per minute and 135 systolic, 90 diastolic, respectively. Is a beta blocker the best initial option for chronic stable angina in JAP? Options for chronic prevention of anginal episodes include beta blockers, calcium channel blockers, long-acting nitrates, and ranolazine. Although each of these options is considered relatively equivalent in terms of ischemia prevention, current guidelines recommend that beta blockers should be administered before a nitrate or a calcium channel blocker when long-term therapy is indicated. Beta blockers are very effective at reducing anginal symptoms and ischemia, including silent myocardial ischemia. Beta blockers also significantly increase exercise tolerance and time to ST segment depression during exercise testing. Several cohort and case control studies have shown that beta blockers improve clinical outcomes, including reductions in mortality in patients with chronic stable angina or coronary artery disease. In addition, recent evidence indicates that beta blockers may also slow the progression of atherosclerosis. In a meta-analysis of clinical trials that compared the 3 classes of anti-ischemics, no differences in long-term mortality were noted. Beta blockers, however, were more effective in lowering the incidence of anginal episodes. Beta blockers are generally considered the most effective class of agents at preventing silent myocardial ischemia. In addition, beta blockers clearly lower morbidity and mortality in patients with coronary artery disease and heart failure. Overall, the body of literature available supports the recommendation that all patients with angina should receive a beta blocker as initial therapy unless contraindicated. JAP at this time does not appear to have any contraindications to beta blocker therapy, and beta blocker therapy should be initiated. The next question reads, how should therapy with a beta blocker be optimized in JAP? All patients receiving anti-anginal drugs should be monitored for frequency of angina attacks and sublingual nitroglycerin consumption. Traditionally, clinicians have monitored the reduction in resting heart rate and have progressively increased the beta blocker dose until the resting heart rate was 55 or 60 beats per minute. JAP currently has a heart rate of 78 beats per minute and preserved BP. If JAP continues to have preserved BP and his heart rate remains above 55 to 60 beats per minute after the initiation of beta blocker therapy, a doubling of his dose would be a reasonable increase, with close monitoring of heart rate and BP. Additional goals with beta blocker therapy include a maximum heart rate of 100 beats per minute or less with exercise. Resting heart rate less than 50 beats per minute may be acceptable, provided the patient is asymptomatic and heart block is not present. Variations in resting heart rate are normal and subject to the influence of the endogenous sympathetic nervous system and other exogenous factors, such as drugs, tobacco, and caffeine-containing beverages. Beta blockers with intrinsic sympathomimetic activity, e.g., pindolol, will not reduce the resting heart rate as much as beta blockers lacking this activity. Exercise stress testing is probably the most accurate, but least practical, method of documenting the adequacy of beta blocker therapy. During an exercise tolerance test, a beta blocker should substantially increase the time JAP walks before developing angina. There also may be a reduction in ST segment depression during exercise, indicating less myocardial ischemia. The rate pressure product probably will be markedly lower, reflecting a decrease in both heart rate and systolic wall tension. An alternative to conducting a formal stress test is to repeat the physical activity which produced angina during this hospitalization, namely, walking a few flights of stairs. The next question reads, would the decision to use beta blockers initially in JAP be altered if he had a history of reactive airway disease such as asthma or peripheral arterial disease? Although all beta blockers are equally effective in the treatment of angina, the addition of reactive airway disease or peripheral arterial disease to JAP's medical history would pose several relative contraindications to the use of some beta blockers. The concern directly relates to the potential for beta blockers to worsen either bronchoconstriction in the case of asthma by blunting beta-2 receptors, or worsening vasoconstriction in the peripheral arteries, again, through blunting vasodilation through beta-2 receptors. Although not absolute contraindications, the presence of these disease states warrants careful monitoring of beta blocker therapy during initiation and titration. Cardioselective beta blockers, such as metoprolol, are often considered in patients with reactive airway disease or peripheral arterial disease with the hope that beta-2 receptors will be unaffected. In one meta-analysis, cardioselective beta blockers were better tolerated than non-selective beta blockers in patients with asthma. Cardioselective beta blockers also are less likely to inhibit beta-2-mediated vasodilation in the peripheral arterioles. Therefore, cardioselective beta blockers are preferred over non-selective beta blockers for patients with peripheral arterial disease and Raynaud disease. Unfortunately, cardioselectivity is not an all-or-none response, instead, it is a dose-dependent phenomenon. As the dose is increased, cardioselectivity is lost. The dose at which cardioselectivity will be lost in any given patient cannot be predicted, and even a very small dose, e.g., metoprolol 50 to 100 mg, could cause wheezing. If beta blocker therapy is to be initiated in a patient with reactive airway disease or peripheral arterial disease, close monitoring for worsening of symptoms should occur and an alternative anti-ischemic medication should be used if symptoms worsen. In the event that beta blocker therapy is not tolerated or considered too risky, initial therapy with a heart rate controlling calcium channel blocker is the next best option, provided there is adequate heart rate and BP to tolerate therapy. In patients who already have low heart rate and/or marginal BP, ranolazine may be considered as an initial option. Long-acting nitrates are typically reserved for add-on therapy for reasons that will be subsequently discussed. The next question reads, JAP is being discharged from the hospital today with prescriptions for sublingual nitroglycerin 0.4 mg tablets, metoprolol succinate 100 mg once daily, metformin 500 mg twice daily, and lisinopril 20 mg once daily, and education regarding diet and exercise. Is there anything else JAP should receive for his chronic stable angina? Antiplatelet therapy is a cornerstone in the management of a patient with atherosclerotic vascular disease. Antiplatelet therapy reduces the incidence of cardiovascular disease events such as myocardial infarction, stroke, and death. Although newer antiplatelet options are available, aspirin is still the first-line choice for patients with atherosclerotic vascular disease due to well-established efficacy and cost-effectiveness. The mechanism of action for aspirin's antiplatelet effect is inhibition of cyclooxygenase. By acetylating the active site of cyclooxygenase, aspirin blocks the formation of prostaglandin endoperoxides from arachidonic acid. This inhibits the formation of both thromboxane and prostacyclin. Thromboxane A2 is a potent vasoconstrictor and facilitates further activation of platelets. Prostacyclin, abbreviated as PGI2, counterbalances the effect of thromboxane A2, because it is a potent inhibitor of platelet aggregation and a vasodilator. Although it has been theorized that higher doses of aspirin would produce a higher level of efficacy than low doses, all available literature indicates that low dosages of aspirin, 75 to 325 mg per day, are as effective as higher dosages, 625 to 1300 mg per day, in the treatment of patients with angina. Conversely, as the aspirin dosage increases, the incidence of adverse effects, especially GI bleeding, increases. Therefore, current guidelines recommend a daily dosage of 75 to 162 mg orally for the prevention of myocardial infarction and death in patients with coronary artery disease. Given this information, JAP should be advised to take aspirin at a dose of 81 mg per day to maintain efficacy but decrease the risk of adverse effects. The next question reads, JAP returns to the hospital with recurrent angina 8 weeks after he was discharged. He mentioned he stopped his metoprolol 36 hours ago when he forgot to get his prescriptions refilled. He is transported to the hospital emergency department for treatment of angina unresponsive to 3 nitroglycerin tablets. How could JAP's situation have been avoided? The beta blocker withdrawal syndrome is a rebound phenomenon resulting from heightened beta receptor density and sensitivity, i.e., upregulation, subsequent to receptor blockade. It places patients with coronary artery disease at high risk for adverse cardiovascular events, which may include acute myocardial infarction and sudden cardiac death. An overshoot in heart rate, as a consequence of sympathoadrenal activity from abrupt beta blocker withdrawal, increases myocardial oxygen demand and platelet aggregation. Withdrawal syndromes may be less severe in patients taking beta blockers with partial agonist activity. If beta blockers are to be discontinued, a gradual tapering schedule, preferably for 1 to 2 weeks, should be used. Shorter periods for beta blocker withdrawal, e.g., 2 to 3 days, have been proposed, although the optimal strategy for discontinuation is not known. Ensuring that beta blockers are tapered and that the patient is reasonably monitored for adverse events for the duration of the taper is imperative. Patients should limit physical activity throughout the beta blocker withdrawal period and seek prompt medical attention when angina symptoms become apparent. Patients should be warned not to precipitously discontinue their beta blockers. Failure to renew prescriptions and financial hardship are common reasons for abrupt discontinuation, and clinicians need to have sufficient professional rapport with patients to understand when patients encounter difficulties in obtaining medications. The next question reads, JAP recovers quickly and is discharged from the hospital after 48 hours. He does well during the next several months, but he is still bothered by occasional angina episodes, 2 to 4 times a week. The attacks usually are precipitated by strenuous work and are relieved by rest and 2 or 3 nitroglycerin tablets. The quality and location of the pain are unchanged, although the duration has increased by 1 or 2 minutes. He follows a low cholesterol, no added salt diet. Physical examination is unchanged except for a 20-pound weight loss. Vital signs include the following: supine BP of 119 systolic 76 diastolic, heart rate of 60 beats per minute, and respiratory rate 12 breaths per minute. JAP's cardiologist elected to start a long-acting prophylactic nitrate isosorbide mononitrate, as well as continuing his metoprolol succinate, dosed at 100 mg daily, lisinopril, dosed at 20 mg daily, aspirin, dosed at 81 mg daily, and metformin, dosed at 500 mg twice daily. Is a long-acting nitrate the best add-on option for JAP's chronic stable angina? Long-acting nitrates occupy a key role in the prevention of angina of all types. The goals of therapy are to decrease the number, severity, and duration of JAP's anginal attacks. A calcium channel blocker could be prescribed for JAP instead of isosorbide mononitrate because he has no contraindications to this class of drugs. A calcium channel blocker would have been a good alternative if his BP had remained elevated, but for now, JAP's BP and pulse are within a desired range. Nitrates can also affect BP, but will likely do so to a lesser extent than calcium channel blockers. Because sublingual nitrates were well tolerated by JAP, a long-acting nitrate would be acceptable. If a calcium channel blocker is considered at this point, a dihydropyridine should be used because they have no effect on heart rate, unlike diltiazem or verapamil. Lastly, ranolazine would be an option for add-on therapy, especially if JAP experiences any adverse hemodynamic effects from either a calcium channel blocker or long-acting nitrate. Ultimately, the decision for additional therapy is based on the prescriber's personal choice and past experience, as well as the entire spectrum of the patient's disease complex. The next question reads, will JAP develop tolerance to the long-acting nitrate? Although not completely understood, several mechanisms of nitrate tolerance have been proposed, including the increased production of catecholamines, plasma volume expansion, and activation of the renin-angiotensin-aldosterone system. All organic nitrates exhibit similar hemodynamic effects through a common pharmacologic mechanism, yet the differing pharmacokinetic profiles of the nitrate delivery systems lead to a variation in the development of tolerance. Short-acting formulations, e.g., sublingual nitroglycerin, oral nitroglycerin spray, and sublingual isosorbide dinitrate, are not likely to induce tolerance given their rapid onset of action and short duration of effect. Oral nitrates and transdermal products, both having an extended duration of action, are likely to induce tolerance. Intermittent application of transdermal nitroglycerin can limit tolerance development in patients with both chronic stable angina and heart failure. The effects of continuous 24 hours per day and intermittent 16 hours per day transdermal nitroglycerin 10 mg per day were compared in 12 men with chronic stable angina who also were being treated with beta blockers or calcium channel blocker. Nitrate efficacy was maintained with intermittent treatment and an 8-hour nitrate-free interval. Tolerance to the anti-anginal effects occurred, however, with continuous treatment. 12-hour intermittent patch therapy also prevents tolerance. The minimal time necessary for a nitrate-free interval is unknown. Nitrate dosing schedules should be arranged to permit a nitrate-free interval during which time the patient may receive angina protection from beta blockers, calcium channel blockers, or ranolazine. Most often, this nitrate-free interval is arranged during the night because angina is more likely to occur during the workday. Patients with nocturnal or early morning angina should arrange their nitrate-free interval during the day. Despite the availability of nitrate preparations that can be dosed once or twice a day, isosorbide mononitrate, oral isosorbide dinitrate is still commonly used in a variety of settings for the treatment of angina. Isosorbide dinitrate needs to be dosed 3 times a day, and presents a challenge in ensuring patients have a nitrate-free interval. If JAP were to receive isosorbide dinitrate, he should take his oral nitrate at 7 a.m., noon, and 5 p.m. because his exercise-induced angina is likely to occur during daylight hours. If he were to take isosorbide dinitrate on a more traditional 3 times a day or every 8 hours schedule, he would be in danger of not having an adequate nitrate-free interval. Because long-acting nitrates must be dosed intermittently to avoid tolerance, metoprolol therapy will provide JAP with continuous protection, even during the nitrate-free interval. Although JAP uses a long-acting nitrate, he still will respond favorably to sublingual nitroglycerin. No evidence indicates that use of long-acting nitrates leads to resistance or tolerance to the effects of sublingual nitroglycerin. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 305.